Hi, this is Sherry Bargan. This is week 2 of your lectures on for Pratt Community College Pharmacology class. This is Unit 3 of week 2. This is on drugs for pain management, both non-narcotic and narcotic analgesia. Pain, as defined by the International Association on the Study of Pain, is an unpleasant sensory and emotional experience related to tissue injury. Due to the subjective nature of pain, the nurse needs a strong knowledge and skillful assessment abilities to measure pain. The goal in pain management is to achieve optimal pain management, whatever that might be. Inflammation. Let's go back a minute. Pain and all types of pain have to be addressed. It's one of the most important skills that a nurse can develop. It is so important that it has become a fifth vital sign that we are very aware of, that Joint Commission watches whether or not we're measuring it and treating it effectively. It is something that is every patient that they come to the hospital, they may be having pain and they may need to be treated for that. Inflammation is a reaction to tissue injury, and this injury can be caused by anything, by infection, trauma, surgical interventions that we do, extreme heat or cold, or even caustic chemical agents. So these all cause an inflammation to the tissue, and in response to that, there's a whole inflammation cascade that takes place. And this is caused by the release of the chemical mediators within the body that trigger both a vascular response and the migration of fluid or cells, like the white cells, to the injured site. The chemical mediators that take place are important to know. The first one on the side is your histamines. The histamines cause a dilation of the arterioles and an increased capillary permeability, allowing more fluids to leave the capillaries and flow to the injured area, thus bringing what that site needs. Then you get the kinins in there, the bradykinin. Those also increase the capillary permeability, and then starts the sensation of pain. Then you have the prostaglandins, and they get in there and they cause an increase of the vasodilation and the capillary permeability, and now more pain and fever. Now this is all part of the healing process, but that pain is coming from both your kinins and your prostaglandins, primarily your prostaglandins, and that's where we look at to try to break that cycle. So first on the scene then, you have your non-steroidal anti-inflammatory drugs, your NSAIDs. They are drugs that were made to inhibit the chemical mediators that we just talked about, and thus decrease inflammation process, and hopefully also decrease pain. Your first NSAID that you know of is aspirin. Its NSAIDs are aspirin-like drugs. So aspirin is the first one there. Then you have your COX-2 inhibitors. Those are let's back a little bit up about COX. COX is cyclooxygenase. It is an enzyme that's responsible for converting arachidonic acid in the prostaglands. Remember we talked about those a minute ago. They break it down, and there's a COX-1 and a COX-2. COX-1, it protects stomach lining, and it regulates blood platelets, for clotting factors. So that's its job. But COX-2, it triggers inflammation and pain. So COX-2 drugs were made to kind of block that COX-2, thus COX-2 inhibitors. The only NSAIDs, these are all NSAIDs, and the only NSAIDs that are over the counter, they are aspirin, and then you can get ibuprofen or Noxprin, which is a lead. Those are the only over-the-counter. And ibuprofen, of course, is your Motrin and drugs like that. A lot of them are just listed as the generic ibuprofen. The rest are all by prescription. The next non-narcotic is your acetaminophen, your Tylenol. This is a non-opiate. It is not an NSAID, and it's not any good for anti-inflammatory properties. It is the 25% of all over-the-counter purchases contain your acetaminophen, and it's in many products. Some of the ones you can get over the counter, like Actifed, Excedrin, Midol, those have the acetaminophen in it, as does Darvocet, Vicodin, Percocet, Lortabs that you get with prescription. It is absorbed in the GI. It's PO, you can get it PO. Rectally, some of that absorption is kind of erratic. That's due to whether or not the rectum and the colon is full, or if there's a slow blood flow to that colon. It's metastasized 85% within the liver, and it weakly, not weakly, I mean, it doesn't do it very strongly, inhibits your prostaglandin synthesis, thus by reducing the pain sensation. It has a rapid onset, and it lasts 5 or less hours. Now, its uses are for relieving pain and discomfort, headache, and it has a good effect on fever. It helps reduce that. The problem with it, though, is it is metabolized so much in the liver that you have to be very careful of getting overdoses on that. An overdose of acetaminophen into the liver is toxic to the liver cells, and death may occur in anywhere from 1 to 4 days, depending on the serum levels. And you die from a hepatic necrosis, which is very, very painful. It's an emergency situation, you're hospitalized, and the antidote for this, and something you should know, the antidote for this is mucomist or acetylcysteine, which is dosed on serum levels. So that's something you should know about that. Well, let's talk a little bit about narcotic analgesics. Narcotics are prescribed for moderate to severe pain, and the first ones were opiates. Opiates have been around since, there's records of them being around since the 300s BC, used for pain relief. There was a lot of abuse of that, like there was in other drugs in times we can remember, but back in the early 20th century, and there was a lot of abuse of opium going on. And in 1914, the Harrison Opiate Act was formed that stated that, well, it required all forms of opium that was sold had to have a prescription. You could not use any amount of opium within a non-prescription drug. And then to just further that, then when 1970, like we talked about before, and you had on your assignment, about the Controlled Substance Act, and that was a way of classifying addictive drugs. So we've had issues with addiction of drugs for a long, long time. Okay, opiates not only decrease pain, this is something you have to think about them, and opiates that come to mind easily and able to think about is codeine and morphine. Morphine being the stronger of the two. Codeine's not quite as potent as morphine. But with these drugs, they not only decrease pain, they also decrease respiratory rate and coughing. They decrease the coughing by acting on the respiratory center in the medulla of the brainstem. So you have to be kind of careful with those. So not only are you going to reduce pain, you may make them so they're not breathing quite as well. So that's something very important to think about. Morphine is a very potent opiate analgesic. It's used for severe pain in the IV form, and you can give it PO, but it's somewhat erratic in how it's absorbed, so it's not as good. It's also, there's forms that are rectal, and there's epidural we can use it for. It's a very good drug to be used for relief of pain from the acute MI. It also helps then with the oxygenation issues within the heart, because it relaxes those muscles out there, the vessels. It's a good drug for cancer pain. It also, when you get a pulmonary edema developed, it's a very good drug for helping to decrease the dyspnea, the pain of the dyspnea. We use it both pre and post-op pain in the hospital setting. And as I said, it relieves the severe pain, but you also have the decreased respiratory drive. You can have orthostatic hypotension, meaning if you give them the drug and they stand up, they'll pass out. The meiosis, and you also have some problem with urinary retention, and like most all of your narcotics, you have constipation, especially in the long term, so that's something to kind of think about on these patients. An overdose of opiates, especially like morphine, the antidote for that is your Narcan or your naloxone. So you have to remember about that. We'll talk a little more about that in a bit. It's morphine is 30% protein bound. It is one of those kind of drugs. It's the first hepatic path drug, which means the liver metabolizes the drug before bioavailability to the rest of the body. It has a short half-life. It crosses both the placenta and into breast milk, so you got to think about that. And it's 90% excreted into in the urine. Now codeine, it's not as potent as morphine. It's only about 1/15 as potent, and it's good for mild to moderate pain. And it has the suppressive cough effect to it, so it can also be called an antitussive. Side effects from codeine, though, are, of course, the constipation, also some nausea and vomiting. It can be given PO, sub-Q, IM. It's not given IV. And it's one of those drugs that's also combined in other things. You can do a combo with Tylenol, for example, for pain, and you get the synergistic type of a response. It is pregnancy listed as a category C or a D. It's protein bound at 17%, and it has a half-life of 2.5 to 4 hours. Now those were the true opiates that they developed from the plant that they then made from that. Some of the synthetic narcotics that came along a little later, one of those is Demerol or mepepridine, which was one of the first synthetic opiates. This was developed in the 1950s. It's shorter acting than morphine. It is a Schedule II drug. Potency varies with this drug with the dosage. You can give it both PO, IM, IV. The PO version, though, is most effective for GI procedures, but so are the others. It works pretty good for any of that. This is a better drug for pregnancy. It does not decrease uterine contractions, and I'm talking for during labor, not during your entire pregnancy. There's no decrease in the uterine contractions with the use of Demerol, and there is not a neonate depression in their respirations. So you can use that during labor. If you have any liver or renal insufficiency, you would want to decrease the dosage amount. It's a good choice for chronic pain. Oh, I'm sorry, it is not a good choice. I got a little confused with myself. I was looking at the morphine roll. It is not a good choice for chronic pain. You should not use it for severe liver dysfunction. That you should avoid that. It's not good for sickle cell, seizures, anyone with seizures, because it can exacerbate that. Not a good one for any long-term use, or if a person is having cardiac dysrhythmias. Also, if there's alcohol involved or sedative hypnotics, avoid Demerol because it will increase the CNS depression. One of the major side effects with Demerol is that hypotension, so you'd have to be careful and monitor your patient carefully. And then you have Dilaudid. Now Dilaudid is used quite frequently within the hospitals, especially in the ICUs. It is similar to morphine in a lot of ways. It's a synthetic narcotic, but it is 6 times more potent than morphine, but it has fewer hypnotic effects of it. It also has a decrease in the respiratory distresses that come from morphine and codeine. It is a Schedule II drug. It is good for moderate to severe pain. It has a PO, a rectal, a sub-Q, IM, and IV dose. The IV dose, you must dilute it prior to using it and has to be given very slowly. It's readily absorbed and excreted in the urine. You must monitor your respiratory rate and keep the patient well hydrated. The side effects you really need to watch for that is your orthostatic hypotension. You don't use it in head injuries. That is due to the decreased respiratory pattern that you have will increase your CO2, thus increasing your intracranial pressures. So that's not a good thing to use in head injuries. Some of the other side effects are adverse reactions with narcotic and analgesia. Is, like we said, the respiratory depression and the orthostatic hypotension, but there's also a component to it that's the tolerance and dependence. And of using it, then the patient then will become tolerant and need larger doses, or may become dependent on the medication and then have to go through withdrawal on that. Contraindications, again, we talked about the head injuries with the increased ICPs. Also, clients with respiratory disorders, like if a patient is having an asthma attack, you wouldn't want to give them some of these narcotic analgesics because it would decrease their respiratory rate even more so. Also, patients with either shock or hypotension, their blood pressure couldn't handle it because they're already so hypotensive. You need to correct the hypotension, and then you can correct the pain with a narcotic. We'll talk a little bit about the narcotic agonists versus antagonists. A while back, there are several meds that were made that the thought behind them was if you made a med in which the opiate antagonist was added to an agonist, then the medication that was added, it was hoped to decrease opiate abuse. And some of those drugs, the one that first one out was Talwin, which is either comes PO or injected. It is a Schedule 4 drug. There's still, patients can find still can cause a dependence for that. These are good though, they're used for pain. The Talwin can be safely used during labor, but these are not good drugs for cancer patients due to the risk of potential CNS toxicity with them. Another one of those narcotic antagonists that we talked about a little earlier, that was your Narcan. That's the most commonly one used. In fact, the other two, in my years, I haven't seen the other two used, but Narcan, that one I've seen used a lot. It is an antidote for an overdose of natural or synthetic opiate analgesics. So any of your opiate analgesics, whether they're natural or synthetic, and you've got an overdose, the first thing you're going to pull out is you're going to use some Narcan on them. The one thing you've got to remember about Narcan is you have to monitor it closely, because the opiate action may exceed that of the opiate antagonist, and then you'll need to give further medication as needed. Along with the narcotics, we have to talk about the narcotic addicted people. And what do you do to treat them? Treatment for a person that's addicted to any opiates, anytime you suddenly withdraw these opiates, they're going to have symptoms and rebound pain, increasing symptoms. They'll not only have withdrawal symptoms, but now they'll have the rebound pain. Signs and symptoms of this are usually diarrhea, abdominal cramps, restlessness, watery eyes, runny nose, and nausea. One type of program that has been put in place to help treat these people is a weaning program, and there's a maintenance program. Is a methadone treatment programs. That actually replaces the opiate with the methadone, and it helps decrease the dependence. Okay, let's get to your case study, and this is something for you to think about. We use a lot of these in the hospital setting. If a client has cancer, is receiving morphine via a controlled anesthesia, a PCA pump. So, what are pertinent assessments for the client receiving morphine via the PCA pump? So you kind of need to think about what are the common side effects, what are the adverse effects of morphine, because now you've got a patient that's getting small amounts at at his leisure, depending on what was set. And if those settings aren't correct or not, you may have issues. So that's something you need to kind of think about a little bit. Practice question number 1. Which drug can reverse respiratory depression in a client who is receiving morphine via PCA pump with respirations of 10? We just talked about it. That's Narcan. Narcan or naloxone is a narcotic antagonist and an antidote for narcotic analgesia overdoses. Practice question number 2. Which is the common side effect or adverse effect of morphine? And of those that's there, it is urinary retention. Diarrhea? Nope. It's more, it'll cause constipation, it will cause hypotension, and it will cause decreased respirations. Alright, thanks. That's the end of Unit 3. I'll get ready to do number 4. See you soon. Bye.